A university hospital operates as a complex ecosystem. It is a space where high-acuity patient care must constantly balance with academic research and the hands-on teaching of new medical professionals. That academic structure is currently colliding with a rigid external framework. The hospital is integrating with CISREG, the state's algorithm-driven system for regulating public health appointments. This requires a standardized operational shift. For decades, scheduling was decentralized, with doctors managing their own clinical agendas. Now, the hospital is enforcing a centrally regulated quota system to meet state demands. Applying a standard throughput algorithm to an academic environment creates immediate structural friction. A high-volume schedule for a professor cannot be mandated without disrupting the hospital's teaching model. To solve this, hospital administration issued an operational directive on March 18th. They established a mathematical framework to force compliance across the board while isolating and protecting teaching functions. We're going to break down the logic of this algorithm. We'll look at how the hospital translates state regulations into daily clinical formulas to hit a mandated target of over 6,400 monthly patient vacancies. The first step in the administration's algorithm replaces the base unit of hospital production. Planners no longer calculate capacity based on individual physician availability. Instead, the calculation is anchored to the mandated throughput of the physical room itself. Management established a numerical rule for this space. Any room designated for a clinical specialty, like pulmonology or cardiology, is required to accept exactly 2 first-time SIS-Reg patients per session. Surgical specialties operate under a higher volume mandate. Those physical rooms are algorithmically programmed to absorb 3 first-time patients per session. Management applies these classifications strictly. Dermatology, for example, is administratively treated as a surgical specialty in this algorithm, requiring a 3-patient quota. By establishing this room-based baseline, the administration can forecast and dictate total hospital capacity independently of individual physician preferences. This room-based logic has a primary vulnerability. Left unchecked, automated SIS-Reg appointments would flood academic environments, leaving professors with no time to instruct residents. To defend against this, the administration built the professor exception. This logic gate acts as a firewall, blocking standard automated SIS-Reg allocation from entering any designated teaching room. Vacancies are only opened inside these protected rooms if a strict opt-in condition is met. The first condition for bypassing the firewall relies on historical precedents. If hospital records show a professor has voluntarily attended CIS-Reg patients in the past, the system will open a matching number of vacancies for them. The second condition requires an explicit SEI document. SEI is the government's official electronic documentation system. A department must file a formal record naming the professional and the exact room before the system allows vacancies through the gate. Even when professors do opt in, their total patient quota is frozen. Management cannot administratively increase a professor's patient load beyond what is documented. This firewall isolates the hospital's academic variables. It protects the university's teaching mission while ensuring the facility contributes to the macro volume targets. To audit whether departments are meeting these calculated capacities, the hospital uses a phased rollout strategy called faseamento. Departments that successfully meet their Phase 1 targets are granted autonomy over their internal distribution. Pneumology, for instance, proved they could hit their requirement of 336 slots, allowing them to manage their own schedules. Cardiology also met compliance. They exceeded 400 total slots by combining standard consultations with specialized exams like Holter monitoring. Other departments undersubmitted their capacity. Infectology fell short by 20 slots, and neurology missed their target by 4. When departments fail to hit their algorithmic target, management pulls the deficit lever, revoking departmental autonomy to ensure the hospital meets its contractual obligations. Management takes the missing quota and forcefully distributes it. The deficit is divided equally and inserted across all of the department's active outpatient rooms. This override algorithm only targets standard non-professor rooms, ensuring the academic firewall remains intact. By standardizing the numerical response to non-compliance, the administration ensures that internal departmental resistance will not compromise the hospital's overarching contract with the state. Translating these theoretical room capacities and academic firewalls into reality requires meticulous manual tracking, visible in the 2026 operational calendar grids. This document shows the 2026 scheduling grid for the medical clinic. The system blocks dates in September and October because second-year residents are attending conferences. If the hospital fails to track these resident rotations or vacation blocks, SIS Reg will automatically book patients for staff not in the building. The grids manage the separation of standard vacancies from PPI quotas. PPI represents slots contractually reserved for patients transferred from other municipalities. Looking at the cardiology grid, we see a cap on this volume. The schedule dictates a maximum of only 6 integrated PPI vacancies per month. Reconciling human resource variables with rigid regulatory demands requires constant administrative coordination, verified month by month. This is the hospital's Phase 1 vacancy plan. It shows the cumulative effect of these algorithmic rules, resulting in a total monthly output of 6,435 first-time patient vacancies. That number is a hard contractual mandate that dictates the hospital's funding and survival under the state management model. To hit it, the administration relies on 3 pillars: standardizing output by room, firelocking academic functions to protect teaching, and reallocating departmental deficits. A university hospital cannot bridge the gap to state regulation, relying on historical, relationship-based scheduling alone. The volume of data is too extensive. The transition is structurally complex, but it creates a mathematically enforced system. It builds a grid that satisfies external production demands while shielding the internal necessity of teaching. The target of 6,435 vacancies represents a systematic transition, a shift from decentralized medical scheduling to a high-throughput, algorithmically managed health system.